Hi, I'm stepping in for Linda. So my name's Amy WallmanMadden, and thank you so much for your time to listen to these ongoing concerns. This isn't Linda's language, so I apologize, so I'll try to tweak it. But our request today includes your consideration to continue to fund the Direct Care Workers Initiative to ensure that funding is adequate for counties to responsibly manage existing services. In the 90s, Linda began to explore starting her own agency after her daughter had received services in 6 different counties, going from an institution, the Mental Health Institute, to Woodward Resource Center. And in 2004, we started H.O.P.E and opened it officially for business. We primarily provide services of supported community living and wraparound supported employment. Our satisfaction surveys result in 98 to 100% from participants and their families, and our turnover of our direct care providers is low. We feel that much of this has become because that we have implemented a training and credential system personally through H.O.P.E. and which has turned into a career pathway, which we started in 2005. Our direct care providers actually pay to take this training, and folks that have taken this training, we have retention rate of over 80%. So we really feel like we're onto something with this. The legislators have already recognized that this is a need for the largest workforce in Iowa that includes over 73,000 providers. This also includes CNAs, home health aides, supported community living providers, personal assistants, and universal workers, and many, many more. Some of the goals of this curriculum include a credentialing system to assist in professionalizing this field, portability for the direct care worker, reduction in administrative overhead as the credentials are valid for 2 years, and the evidence with this increased training that the direct care provider, there's a direct correlation that has resulted in investment and retention, as we have seen personally. We've looked into the NADSP and the College of Direct Support approximately 6 years ago, and we serve about 65 participants in the Des Moines area, and we couldn't afford this system. The understanding that we have is the cost of this proposed system would not be significantly more than what we're now investing in training. By retaining more credentialed direct care professionals over time and reducing retraining costs when hiring, training costs could be expected to hold steady or go down. The need to support persons with disabilities is increasing, and when Linda's daughter was diagnosed with autism 17 years ago, there were 1 in 10,000 diagnosed. Today, there's 1 in 88. Without a doubt, early intervention is important. Training direct care workers is essential, not only for skill building, but to also allow for the potential of these upcoming constituents to become productive, tax-paying citizens. Thank you for your time.
Thank you, Amy. Kate Gaynor, followed by Matthew Covington from CCI.
Good morning. My name is Kate Gaynor, and I'm the Executive Vice President of the Iowa Pharmacy Association. IPA represents over 2,000 pharmacists in all practice settings across the state. Thank you, Senators and Representatives, for the opportunity to provide input as you consider principles of healthcare reform. I'll focus on 3 areas: medication therapy management and compliance, quality measurement, and health information technology and interoperability. Proper use of prescription medications helps improve quality of life and health outcomes. The cost of adverse drug events from inappropriate medication use is greater than $177 billion annually in the U.S. Proper use of medication becomes even more important as the cost of treating chronic disease continues to skyrocket. Pharmacists have extensive clinical knowledge and expertise in medication use and are one of the most accessible yet underutilized healthcare professionals. Pharmacists are uniquely positioned to improve health outcomes by optimizing appropriate medication use. Medication therapy management, or MTM programs, help drive patient adherence, improve patient understanding, reduce medication-related problems, and therefore reduce costly ER visits and preventable hospital readmissions. The one thing that follows a patient through each care transition is the patient's medications. Medication reconciliation at each care transition is an important part of MTM. We urge the state to consider a performance measurement system that evaluates quality related to medication use in any state-based prescription drug plan. Medication quality measures are currently used in Medicare Star Ratings. Insurance exchanges can use a performance-based system to incentivize medication compliance. Pharmacists providing MTM and utilizing quality measures can impact patient care to improve adherence, especially in patients with chronic disease, as well as improving the cost-effective vaccinations and other preventative care services. Allow pharmacists to work with physicians and other healthcare providers and practice at the top of their degree by including MTM services and quality measurement programs that utilize pharmacist skills to improve patient outcomes and decrease healthcare costs. Lastly, as health IT evolves, pharmacists should be able to interface in an electronic, interoperable healthcare system to provide the best possible quality of care to patients. Information obtained through interoperability will help pharmacists provide MTM, resulting in enhanced compliance of medications, reduced adverse drug events, and improved healthcare provider communication and decision-making. IPA urges policymakers to act boldly and creatively to improve care for Iowans while increasing the use of preventative services to keep our state healthy. Decisions made to reform healthcare should fully enhance, recognize, and utilize the professional skills and competencies of pharmacists. Including pharmacists in a patient-centered model of care will improve the health of Iowans. Thank you.
Thank you very much. Matthew Covington, and then Scott Sundstrom.
Matthew Covington, Iowa Citizens for Community Improvement. To be perhaps a broken record in case anyone was sleeping, we too are in favor of Medicaid expansion. It is the moral thing to do. It's good public policy. Also, by most indications, it will save the state money. So that is a slam dunk, or to stick with the baseball metaphor, perhaps a home run. Also, much like Anthony had said, Charlie and others before me, we are also in favor of a state-based exchange. However, though time is of the essence, I don't think that is something that we should be rushing into. Much like the forum that you have all organized today, it is something that should have all the stakeholders involved present, their thoughts, their opinions, players of all sizes, so we get people like the caregivers, like direct care workers and others' voices in that. Those are our two main priorities. Rusty, I'm going to save you the trouble of even holding up a card. Thank you very much.
Thank you, Matthew. That is uncharacteristic of CCIs. We appreciate it. Scott Sundstrom, and then Dana Petrowski.
Good morning. I'm Scott Sundstrom, representing the Federation of Iowa Insurers. Just wanted to make a couple of brief comments on a couple of topics. First is the health insurance exchange. And I think as we've all been sitting here this morning, the governor has issued a press release saying that Iowa will be doing a state-federal partnership. So the comments I submitted are a little bit out of date already. Just a couple of comments about the Federation's position on implementation of an exchange. The first is that health insurance regulation is the duty of the Iowa Insurance Division, and we just want to make sure that the exchange doesn't create inconsistent, duplicative regulation in its efforts. Secondly, we'd like to make sure that any exchange advisory board or governing board or whatever structure is ultimately set up includes some representation from the insurance industry. We've obviously got a lot of expertise to offer in that area. We're the ones that are going to be creating the products that are sold on the exchange, and we'd just like to have a voice in that process as that moves forward. And finally, would like to make sure that participation by health insurance carriers is both voluntary for any qualified carrier, but also includes all qualified carriers who do want to participate, to make sure that the exchange has a range of health insurance carriers available. The second topic I wanted to cover very briefly was healthcare costs. I just wanted to raise a couple of red flags about potential issues that could increase healthcare costs that are coming. The first one is just sort of the general environment. Health insurance costs increase because health care costs increase. Health care costs have been going up for a while. That happens for a lot of factors. Increased fees for services, increased utilization of services, and new therapies and services. While new therapies and services may be better, and they often are, they're oftentimes more expensive. So just wanted to keep that as background. And then the second cost area I wanted to talk about was the Affordable Care Act. There are a few features of the Affordable Care Act that we're concerned may force increased costs as it is implemented. The first one is something that's a federal issue, really, and it's the health care or health insurance tax that is going to be coming online in 2014. It's a national tax. It starts out at $8 billion nationally. It's spread across the country. It will increase over time to $14.3 billion in 2018 and then go up thereafter. That is going to have a real impact on the cost of insurance premium because that will be passed on obviously to insureds in a proportional amount. Wanted you to be aware of that. Secondly, when you're formulating the essential health benefits plan, keep in mind that there is a trade-off between the comprehensiveness of benefits and costs. So we just would ask that you keep that in mind when thinking about that issue. And then finally, age rating compression. This is a feature of the Affordable Care Act. It requires that there be no more than a 3-to-1 spread between the rates charged based on age. Generally, older folks are more expensive than younger folks. That will compress rating, and because of that, younger people will pay more potentially. And we just want to be aware of that to make sure that doesn't get so out of whack that young folks are discouraged from participating in health insurance and just paying a penalty instead. Thank you for your time. I appreciate the opportunity to participate today.
Thank you, Scott. Dana Petrowski.